We'll be starting with our next session.
The innovator of MGB, Dr. Rutledge, he will be with us very soon.
Thank you.
Please join us.
Thank you.
Thank you so much, sir. It was very enlightening. It is my immense pleasure to introduce our distinguished speaker for this session, Dr. Robert Rutledge, a true pioneer in the field of bariatric surgery. Dr. Rutledge has been at the forefront of developing and refining minimal invasive techniques in weight loss surgery and has made groundbreaking contributions to the field of metabolic and bariatric procedures. Today, Dr. Rutledge will be presenting on the exciting topic of MGB 2.0, focusing on the advancements and innovation in the Mini Gastric Bypass procedure. We are incredibly fortunate to have you, Dr. Rutledge, with us. Over to you, sir.
You're too kind. May I begin?
Yes, sir.
Yes, we are eagerly waiting for you, sir.
All right, good.
Dr.
I'm going to
Rajesh
share my
Shah
screen.
from India, the president of the World Association of Laparoscopic Surgeons. The whole house is full, waiting for you, sir.
Very good. Can you see my screen, MGB? So good morning, and we're going to talk about surgical treatment for all diabetics. Our belief now, tentatively, is every diabetic who has a moderately severe disease should have surgery earlier rather than late. And I'll see if I can make a case for that. Early surgical treatment for diabetes. Hemoglobin A1C greater than 10 or incipient complications. We think urgent surgery is appropriate, and medications unfortunately only change the delta hemoglobin A1C by 1%, and you need a lot more than that if you want to improve the outcome or survival of such diabetics. So, how do we do that? We recommend MGB-2, and we'll talk a little bit about that today. Earlier in this series, Dr. Kular and Dr. Magenda have shown in their data that the MGB can reverse diabetes in thin diabetics. In 55 patients over 6 to 7 years, their hemoglobin A1C was returned to normal. It's an incredible finding, and it makes sense when you think about it, but we're going to talk more about that and what the advantages of our early operation. The mini gastric bypass is just the MGB, but with some differences. No staples. It's less than 30 minutes, so maybe an hour less for operating time. Same-day surgery, and roughly half or less than half the cost. Hundreds of studies have shown that the Billroth 2 with no other gastric procedure routinely leads to diabetic improvement and reversal. And the MGB is essentially a Billroth 2. And in the past, though, we had included a collis gastroplasty. And so now we're going to bring up questions about that addition. Here's some studies. This is just examples. There are dozens of these studies, in fact, hundreds. Diabetes remission in low BMI patients with the Billroth 2. And in this case, Billroth 2 at 2 years led to remission in half the patients. In other words, just the Billroth 2. And people get all wound up about other parts to the surgery, but just the Billroth 2, 50% remission. And the hemoglobin A1C was 6.1%. So a tremendous example, a recent study, and there are many older studies that demonstrate that a Billroth 2 by itself is an excellent anti-diabetes medication treatment. Okay, what's an MGB-2? Let's talk about it. Well, just remember, if you're a trained surgeon, you know that a Billroth 2, that an MGB is a Billroth 2 with a collis gastroplasty, and that's the gastric pouch. And the MGB-2 is simple. It's a Billroth 2 with gastric plication. So let's look at some x-rays and pictures and see if we can describe it. Here comes an MGB-2. And the reason is we're trying to stop these complications. What's wrong with an MGB? Well, any kind of bariatric surgery has reported rates of leak in the 2 or 3% rate, bleedings up to 20%, stenosis, and these leaks often from perforations and lead to infections and frequently, unfortunately, to death. What's the MGB-2 and how is it related to the MGB? Well, here's some simple explanation. The simple philosophy of the MGB is remove the reservoir function of the stomach. And so the esophageal extension is a collis gastroplasty. That's the idea of the original MGB. This. We wanted to avoid the EG junction, no dissecting the area of the EG junction, spleen, short gastrics. We want a longer gastric pouch. We want to decrease ischemia in foreign body on the lateral aspect. We want to increase the gastrojejunostomy diameter to increase the chance of dumping. We'd like to decrease or eliminate staple line leak and bleeding complications. And we'd like it easily revised or reversed. And so we're going to say like easily tailored also for low or normal diabetics. So gastric plication versus endoscopic plication. Endoscopic plication, gastric plication hasn't really worked very well, but we'd like to point out that the MGB-2 is fundamentally different. So we'll look at that quickly. No one, or almost no one, thinks that plications are a good idea. Actually, the practitioners do them. I don't want to be negative about it, but gastric plication, either endoscopic or laparoscopic, generally has relatively poor or mild weight loss, a high recurrence rate, and laparoscopic plication has other problems, including ischemia and bleeding and perforation. So we don't want that. So here's some examples of plications. These are endoscopic plications, and you can see that they have something that, of course, everyone has, which is a pylorus. And so the reason that the upper part of the body of the stomach that's been plicated has problems over time is because there's a relatively high obstructive outlet here, the pylorus. And there it is, the same thing. And those things over time, we think lead to dilation of the pouch and breakdown of the pouch, and so that's a problem. But on the other hand, the MGB is different. We have a wide open gastrojejunostomy that leads to a depressurizing the stomach. And that's the trick, so to speak, of the MGB-2. We don't have the failures of the other forms of gastric plication. Okay, let's look at an MGB. Here we go. So this is the esophagus. You can see the X-ray dye coming down. There's the gastric pouch. It looks pretty small. There's the gastric pouch. And there we're reaching down into the body of the stomach. This is the junction between the body and the gastrojejunostomy. And there we see, here we can see the antrum and the antrum of the stomach here are partially occluded, and here's the stomach, and then here's the gastrojejunostomy down to the efferent small bowel. There's no filling defect, no filling of the efferent limb, and the esophagus, gastric pouch, and the efferent small bowel are visible here as well. Again, this is the gastrojejunostomy, emptying fast and nothing coming from or going into the afferent limb. And there's some antrum, and you can see now filling, very rapid filling. In the video, we see this happen in seconds, and now it's going into the small intestine. And there it is, filling up the small intestine there, the gastrojejunostomy, and moving along through the various loops of small intestine. And the stomach is emptied in almost no time, and that's what we want. We want to interfere with the stomach's ability to keep fatty foods in there and to divert them into the duodenum. We want to avoid that because that leads to obesity and diabetes. Okay, we're going to do an MGB, but again, remember that the MGB is nothing more, the MGB-2 is nothing more than the MGB, which is a wildly successful operation around the world. So MGB-2 is a Billroth 2 and a gastric plication, and MGB is a Billroth 2 and a collis gastroplasty. Here are the steps. We like to talk about this when we're training new surgeons. Here are the steps in performing an MGB-2. 1, you do a gastrojejunostomy. 2, you plicate the stomach and the antrum, and you're done. Again, it's nothing to it. Gastrojejunostomy, plicate the stomach and the antrum, done. So I let people stop me here when I do this presentation if you have questions. Let's do an MGB. We'll look at this. Here's a view of it. Here's where the new gastrojejunostomy is going to go. The old MGB used to be up here, so that's different. Find the ligament of trites, bring the loop up. Usually this takes 10 or 15 minutes to get here. Then we close that, and this is the gastrojejunostomy, and it's far distant from the old spot from the MGB. This is the MGB-2's location. And this is what you would see here. This is the esophagus ending here. This is the pouch and the stomach, and then this is the junction between the gastric and gastrojejunostomy right there. And so now we're going to plicate the stomach, and we're almost done. The surgery is almost done. So this is the plicated stomach. There's the gastrojejunostomy. You can see up here 2 rows of anterior gastric plication and the antrum, and we will plicate the antrum. That's antral plication. It takes only a moment, and you can see no contrast goes in that direction. If you're a believer in leaving some ability to do that, I don't, but there sometimes might be a reason for it. You could leave a small amount of food to go through and deliver some iron if you believe in that. Okay, let's review the post-op MGB-2 anatomy. Again, here it is. So esophagus, the neostomach, gastric pouch, the gastrojejunostomy. Okay, now, this operation has implications because there is a worldwide crisis, and I'll go through this quickly, but we are in the midst of a tragedy, which is the rising rate, a pandemic of diabetes. Diabetes is causing tragic numbers of deaths, and diabetes is remarkable because we can now, we believe, with data from Dr. Kular and Dr. Magenda, we believe we can reverse diabetes in many thin diabetics. So this is what we're looking at, the diabetes pandemic, the tragic complications, Kular and Magenda's data showing that diabetes is a surgical disease now, we believe, and diabetes can be, all diabetics can be a surgical candidate, essentially, and we believe MGB-2 is the ideal choice for such patients. So let's look at the pandemic. It's a worldwide pandemic with blindness, heart attack, stroke, kidney failure, and amputation. And these are terrible diseases, and so this is an awful thing to face. In the United States, 1 out of 11 people. And these are, again, the diseases. The cost in the United States, $137 billion annually. So it's nothing to sneeze at, as they say. And the rate of diabetes is increasing from 5% in 1990 to 10% in 2020 is the prediction. Costs, $320 to $670 million predicted in 2060. We believe this is essentially a red alert alarm that we need to do something. And so we sit here quietly while this happens, and many people are harmed by this. And we think we can't afford to wait any longer. Let's look at Kular and Magenda's data, which confirm that we have a solution. The MGB and now is a better, simpler, faster, and cheaper treatment to MGB-2. Here's an example of a patient who had an MGB. She presented with a BMI of 25. Her HbA1c was 15. She had a mini gastric bypass in 2018, excuse me, and follow-up in 2024, 6 years post-op, her hemoglobin A1c was 4.7. That's normal. Now, maybe she wasn't cured, maybe she'll get it back and you'll blame that, but to me, her triglycerides were normal, no recurrence of her diabetes, she was on insulin, she's not on insulin anymore, improved quality of life, resolution of sleep apnea. That's from a short-limb MGB, and an MGB-2, we believe, will do the same. This is the data, and basically on 52 patients followed for 7 years, the mean hemoglobin A1c preoperatively before the surgery was 12.6, and postoperatively at 7 years was 6.1. That's not diabetic. So you can say it's reversed or whatever. If I would potentially like to tell the patient they're cured, it might come back if you eat poorly, but if I'm not allowed to say cured, I'd say it's reversed for 7 years. I think it's earth-shaking. Again, this is the same data. Imagine 12.6 to 6.1 for 7 years in 55 patients. Here's the study. Look at this. So 12.6 is arrival. The first year, 7. Second year, 6.7, 6.4, 6.2, 6.1. Every year, better. The MGB makes diabetes better. Here's an example of the C-peptide levels. And what we see is if you wait, C-peptide will tell you that as it declines, the damage in the pancreas is leaving you with less opportunity to have the beta cells create insulin. So once you get to the left end of this screen, these patients are less likely to be cured. They're 8 and 7. And down here, and this is early in the lifespan of a diabetic, what we believe is early operation for diabetes. This is a very radical statement. Early operation for diabetes, early operation for diabetes, and it looks as though maybe we can reverse it. In fact, I don't know, maybe cure. Now, people say, oh, you can't operate on thin diabetics, you can't operate on thin diabetics. Here's the albumin level. And 2 people had a slightly low albumin for other reasons. So none of them essentially had an abnormal albumin except for 2 out of the 55 patients. Here is vitamin B12, and vitamin B12 was actually lower before the surgery. So their surgery gave them a better and improved B12 level throughout the age distribution of the patients we operated on. Almost everyone has a normal hemoglobin A1C, has a normal BMI. If normal BMI is between 18.5 and 24.9, well then 100% have a normal body weight. It's pretty close. Now, we worked with the artificial intelligence and we created a model based on the hemoglobin A1C level. And basically what we were able to demonstrate is that for the 37 patients we had data on to do this study, at 10 years, the projected cost for medicine was wildly different if you had the hemoglobin A1C from before the operation to the hemoglobin A1C after the operation. From $2.8 billion to $900,000, with an estimated savings of $1.8 billion if this is a correct extension of what the cost might be for those patients. So again, this is another way to look at it, that for the 55 patients with hemoglobin A1C greater than 10, everyone was greater than 10, the estimated 10-year medical costs for the patients was $4 million. The estimated 10-year medical costs for similar patients who had a hemoglobin A1C like those in the group less than 7, they were predicted to only cost $1.5 million. That's a savings of almost $3 million. So if you're a hospital, if you are a patient and you want to look not only at the ability to save lives and blindness and other things, the cost savings are gigantic. Now, another study we did is we looked at the risk of cardiovascular disease, and this includes heart attack and stroke. And basically, if you had the hemoglobin A1C of these patients preoperatively, then their risk of having a heart attack or a stroke is above 100% for every single one of them at their numbers. And after surgery, with their numbers in the below 6 range, it was 0. In other words, 100% you will have a heart attack or you won't. And the MGB made the difference. An MGB surgery, maybe 30-minute MGB-2, and you would go from 100% you will have a heart attack, predicted by the model, to you will not. So our conclusions, tentatively, is the following. That knowledge and experience with MGB shows selection criteria tells us we should operate early and liberally. The cost for an MGB-2 is less than a year's worth of medications, depending on the medicines. We can treat now all ages, in our opinion, and Coular's data suggests that the pre-mean hemoglobin A1C of 12 has a 5-year success of almost 95%, getting them less than 7. So it's a rare patient who doesn't get less than 7. We now know the MGB-2 can reverse severe diabetics for at least 5 years and up to 7. Now, a reminder again, what's the Billroth-2? Well, Billroth-2 has been shown to decrease diabetes. And here's Taiwan, it decreased the risk of diabetes from 13% of the population to 6.7% of those who'd had a Billroth-2. This is that Taiwan Nation database. Just the Billroth-2 led to a 50% decline in diabetes with just the Billroth-2. Worldwide, India is a diabetic pandemic, and we believe that the MGB-2 can act as a treatment. Now let's go back and talk about the MGB-2. We think now, this is our tentative opinion, but essentially, if you can be cleared for surgery, you should have surgery. Every diabetic should consider having surgery because the outlook for surgery for diabetes over the long term is poor and sometimes disastrous and terrible and expensive. And a short-term Billroth-2 MGB-2 is simple, easy, and effective. Remember, Billroth did this back in 1885, so that's 139 years ago. And what we know is that patients of ours, here's a patient of Dr. Coular's 10 years after his surgery. His hemoglobin A1C has decreased. Here's another demonstration that the 10-year hemoglobin A1C decreased amputation risk as calculated by some public data. There's over 100 articles where Billroth-2 improves or reverses diabetes. There's animal studies. Here's some more studies, basically Billroth-2. And the reason for it is because we divert the food from the normal route through the duodenum and another article and another article. These are various drugs. They cost a lot of money and sometimes they're not going to be helpful. So we can do better. Surgery once more. Bication of the stomach. There it is, antrum, efferent, afferent limb. Bication of the antrum. Bicated stomach is narrow. Thank you all very much.
Thank you, Robert. There's Arun Prasad here. I had come specially to meet you in person, but I will settle with a virtual hello. So I've got three questions for you. I'll start one by one. First question is, what about weight loss? In MGB-2, do we see weight loss as well? Or should we restrict it only for diabetes?
Yeah, that's a great question. So what about weight loss? Weight loss in the MGB is directly related to BP limb length and not to the size of the pouch. Now, Coular has long believed in the value of the size of the pouch. The size of the pouch makes no difference. Coular, for many years, measured the size of the pouch. And we have good data, it doesn't make any difference. The diameter of the pouch is a belief, in my opinion, like the Roux and Y. In other words, I think sir, that there are many of us who believe that the Roux-en-Y and the MGB are equal as far as power. Yet the MGB, I was criticized bitterly about it has too big a pouch, right? I think the pouch is not critical. In the MGB-2 that we've seen, the pouch size doesn't make any difference.
Okay, my second question is comparing MGB to MGB-2, is there a difference in the resolution of diabetes between the two procedures?
They're basically the same procedure. One is with staples, and what we felt is that the staples were not critical. So we removed them radically several years ago, and what we found is I don't think that the staples are critical. We believe, I think you believe, that the staples are critical, but I radically said, no, I don't think they're critical because I don't think this gastric pouch is critical because I learned that from looking at Coular's own data. So I don't think that the gastric pouch diameter makes any difference, and we now know that plication has been approved. Plication
Sorry, I think you didn't understand my question. My question was, if we compare MGB to MGB-2, is there a difference in its effect on diabetes, or both surgery have the same effect?
The difference is the BP limb length.
So both have same effect on diabetes resolution equally?
Yes, except for when you're doing an MGB-2 for a thin diabetic, you shorten the BP limb.
Okay. My last question is, for someone who has not done MGB, would you advise them that they can start straight off with MGB-2?
No, I think everybody should be trained by me. What we have seen around the world, as you know, is that the MGB has been adopted and done poorly by some and well by others. So in other words, I call this the MGB paradox. If you look at the data on MGB, some surgeons have reported terrible results of reflux. Yet Coular, you and I and others don't have a lot of reflux. That's related to skill, in my opinion. If you do it well, the MGB does not have much reflux. If you do it poorly, then I see reflux and I see other complications of the MGB.
Well, thank you. I think MGB has cured, I would say cured many diabetics in India, and I hope that MGB-2 continues with the good work. Thank you. It was really wonderful listening to you. Are there any other questions?
Yeah.
Anyone? Yeah, we've got one more question.
Dr. Rutledge, what time in your place right now? 6:30 in the morning?
sorry?
What time in your place? 6:30 in the morning? So my question, I'm Sharik Nazir from Columbia, from New York. My question is that in US, I was just presenting data, we don't do mini gastric bypass because it's not been approved by the SMBS. So because of the reflux, And second thing is because of the chances of getting gastric cancer is more higher in mini gastric bypass. What is your message?
Some of my colleagues in America are stupid. Look around the earth. Look at India. How many people in India do MGB? Raise your hands.
In India, I think the second popular operation after sleeve.
Yeah, okay. And what's wrong with America? I cannot tell you.
Thank you, sir. It was very, very inspiring information, and we cannot take any more questions because of shortage of time. I would now like to call upon, yes, a big round of applause for sir. Yes, indeed.
Thank you and goodbye.